Hello.
Good
Hi.
morning.
Morning.
How's the dogs? On camera, so we can
We'll just give it a few minutes for some stragglers to join.
Can I just say, when I've been logging into the portal, it keeps asking me to verify my email address. Is that going to be every time now? Because I've logged in twice this morning and it's asked me to verify it twice.
Joe, do you want to answer that?
I can. The reason it's asking you to verify your IP is because your IP address changes on your device every time that you log into Wi-Fi when you first turn it on. So it's just confirming that it's still you trying to log in. That may happen more frequently than not. You may have it happen every time you try to log in. It may happen like once every so often. It isn't. It's just a security feature to make sure it's yourself, rather than say someone else who may have obtained your password and your login and is pretending to be you from elsewhere in the world, for example.
Okay. It's just funny how both times this morning it's done it then. Is that just an extra security thing? It's not just going to do it every single time then?
It depends on how often your IP address changes, which is something that's determined by the internet service that you log into. So if you're using, for example, say Wi-Fi in a hospital and you switch between different Wi-Fi access points, you'll get a new IP address when you transition from one to another, and it will then prompt you if you then log in again to confirm it's still you.
Because this was on the same address. This was on my laptop, literally within an hour of each other this morning. So
yeah. Whatever network you connect to gives you a brand new IP address more often than not when you say switch different locations, or even going to change them throughout the day. It depends on the service provider's settings. Are you logging in from home, I take it there, Lynn?
Yeah, I am at the moment, yeah.
Okay. What you might wish to do then is if you check with your ISP, they may be able to give you what's called a static IP address if you ask them for that specifically. That would then mean that your IP address on your laptop doesn't change, and therefore you won't be asked to verify your IP unless it is the case that you were to go to, say, a new Wi-Fi access point, say a hospital public location, and at that point then it would ask you to verify, but it wouldn't keep asking you to verify in your own home. What I can do, by the way, is later on in this presentation I'll be providing you all with contact details for how to email myself, and I would be more than happy to give you further instruction on that if you need at that point. Would that be okay?
Yes, thank you. Yeah.
Great. Excellent.
Okay.
I wanted to ask about the nhs.net addresses as well. Shall I ask that later? Are you wanting to get started?
Hopefully we'll cover it through the presentation for you. So hopefully, yeah, any questions you've got, we'll be able to cover with a bit of luck.
Is Claire with us, Hazel?
No, she's not back in yet.
Okay. Unfortunately, one of our presenters, their computers have forced an installation job requiring a restart. So maybe we've got a few minutes, Lina, to answer that question. Sorry, contradicting what Hazel just said.
Yeah, I can certainly do that. So what it is the portal requires you to use either an @nhs.net address or an address that's verified to what is called, I believe, DC 1596 standard. What that basically means is the NHS, NHS Digital specifically, have a email domain standard that, if met, allows you to transfer PID, patient identifiable data, between email addresses that meet that standard. So, for example, your average Gmail account is not accredited to that. Hotmail, for example, as well. NHS.net by default is, and certain .nhs.uk addresses and some others are accredited to that as well. Okay. So when you register for the portal, if you don't have an nhs.net address, that's not necessarily the end of the world. It won't be a deal breaker immediately. What you would need to do is check that your email address is verified as compliant with that standard. And then if it is, we will then put the registration through for you, no problem. If it's not, you'll need to get it updated to that standard, with which you would need to contact your local IT help desk. As I mentioned before with the IP verification thing, though, that is a lot to cover, understandably, and a lot of jargon there. So I'm more than happy for you to, once I've given the details out later in this presentation, to contact me directly. I will point you to the website where this is all detailed, and it will give you instructions on how you can get to that standard and confirm that your own email fits that criteria.
Okay, it should do, but yeah, when I tried to register with our local one, it wouldn't let me. So I have actually registered with nhs.net with my account.
Okay.
But all our nhs.net accounts in Notts County are being removed because our Notts County address is more the secure one now.
I see.
So we're only, yeah, so I'm going to have to get it updated with your IT world.
Yeah.
That our notswitchc.nhs.uk will be accepted.
Sure. Contact me after the meeting then, Lynn, and I'll help you through with that. And what will happen is, because you mentioned your NHS net is being deactivated, what we'll simply do is once we've got your email up to the necessary standard, or indeed confirmed it is already there, I will simply amend your existing registration to use that email rather than having you re-register again. Saves you the time.
Well, thank you. And then that's all my Part B prescribers as well. So I'll have to send you the list of everybody's names. Or is that how it'll work? Or
yep, you're more than welcome to do that, and I'll take care of it for you.
Okay, that's great. Thank you.
Okay,
Claire, we have Claire back with us now.
Okay, brilliant.
Timing.
I'm here now. Yeah.
Okay, so we will.
Morning.
Morning.
Hi.
I'm on now. Lovely. Yeah, I'm here.
Hello.
Yeah. Thank you. Bye. Morning.
Oh.
Thank you.
Hello.
Hello.
Hello. Bye.
Okay, so I think we are present, or mostly present and correct. There may be a few who will join us in the next few minutes, but want to say welcome. Welcome to BOC's Getting Started with BOC webinar, and this is for Part B home oxygen prescribers. So if that's not you, sorry, this might not be the webinar that you intended to join. So the reason for this webinar today is because on Monday the 19th of October, BOC Healthcare will take over from Air Liquide as your regional home oxygen service provider. My name's Claire Roof. I'm BOC's transition lead, and I'd like to thank you again for joining us today. With regards to the transition, the change of provider, this time round, unlike previous HOS contract transitions or renewals, there are really not that many changes for you to be aware of as a prescriber, and actually even fewer for your patients. But the main change for prescriber is that under the new contract, HOOFs must be submitted via the provider's portal. So that's not our ruling, that is NHS England's ruling. Plus, given the change from Air Liquide to us, you'll need to update your contacts book with our details. So those really are the main changes that will affect you from day one. So today is focused on getting you started with BOC so that you're ready and able to submit HOOFs, to change existing HOOFs with your existing patients from Monday the 19th of October when we become your provider. It's really an introductory session to give you what you need to be able to manage your patient's oxygen equipment from the 19th. We plan to run some further webinars soon after go live, so after the 19th, to get you more familiar with our portal. Those sessions will take you through the individual patient dashboards and the reports that you and your administrators, if you have them, will be interested in and need to help you manage your oxygen patient caseload. The reason we're doing those after go live is, at the moment, as you will have seen if you've gone into the portal, we don't have your patient data yet, so it's not accessible on the portal, and until the patient data is in the portal, the reports probably don't make any sense to you until you can see that there's data in them. So we'll run those webinars after go live. So by the end of today's session, then this introductory session, we are aiming for you to know how to find your patients on the portal, how to create and amend a HOOF, to be familiar with the equipment that we will be bringing into the region that you're not that you don't currently have within the service, and equally, because we are BOC and it's our mantra, to hopefully for you to be reassured by our prime focus on patient safety. So taking you through the session today will be this team of colleagues who come with many years experience of delivering the home oxygen service from their different and respective functions. We'll start by introducing ourselves. I'll go first. As I said, I'm Claire Roof. I'm responsible for managing the transition, the project of it. I'm working with your regional contract lead, Priya, and your regional clinical lead, Wendy, to ensure that the handover from Air Liquide goes as smoothly and as safely for patients as possible. So I'll hand over to the other Claire.
Hello, I'm Claire Murphy and I'm the clinical lead for BOC. So I have oversight of the home oxygen regions, and also I double hat and clinically lead a variety of services from HOSAR to rehab services as well. So yes, hello.
Hi, good morning. I'm Hazel O'Mara, and I'm the Patient Service Centre Manager based up in Worsley. So I look after the team there that are the first line contact for patients and for yourselves.
Hi, I'm Niall Farrow and I'm the home care team manager for the East Midlands. So I look after the engineers, and so we'll be like the face of BOC to the patient. And I'm sure I'll end up working closely with yourselves as well. If we have any complex patients, any concerned patients, things like that. Yeah, thank you.
And hi everyone, my name's Joe Dillon. I am one of 2 data analysts for BOC Home Care. I'm responsible for providing ad hoc and structured reporting, so you get your regional monthly reports, ad hoc requests, and of particular interest to me, I am the expert user for the portal, so I will be your first line of contact for anything portal related, be it feedback, queries and comments, any issues you may have, anything you require assistance with.
Okay, before we move on, and because the participant numbers are manageable, we thought it'd be nice if you could each briefly introduce yourself, just your name, your role, which team or organisation you work in, and it would be of interest to us to know whether you're already using Air Liquide's portal. So Hazel will call you up one by one. And so, yeah, if you just spend a few minutes introducing yourself, and don't forget to unmute your mic.
Okay, Niall, have you raised your hand for a reason?
I need to just make my apologies. Sorry, I forgot. I'm currently at our Lincoln site dealing with the comms install, and I forgot to make my apologies. Yes, I need to leave very shortly. So sorry for that. Thank you.
Thanks, Niall. I'll just go down the list in participants. It's in alphabetical order. So if I start with Anna. Anna, would you like to introduce yourself and say hello? Well, maybe we'll come back to you. It looks like we had Caroline, but I'm not sure if Caroline's has just left. Caroline, are you still there? Oh, this is a good start, isn't it? Lynn, I think we've already spoken to you. Are you still there?
Me, Linny, yeah, I'm
hi,
here.
Linny.
Hi. Sorry, I've got requests for another call, another meeting coming through. So, yeah, hi, I'm Linny Bush. I'm the clinical HOS lead for, well, we've sort of amalgamated as one CCG now, so Nottinghamshire CCG. I cover NNE and Rushcliffe CCGs within that. So I work with, so I have 2 bases. So my Nottingham North and East base is in Carlton, and I work within the adult integrated care team there. And we have respiratory nurse specialists, respiratory physiotherapist specialists, and then just the district nursing team and the therapy team. And my base in Rushcliffe is at Keyworth Health Centre, and I sit with the cardiorespiratory team there. So we've got heart failure nurses, respiratory nurse specialists, and respiratory physiotherapists. So.
Lovely, thank you very much. Claire, you're next on my list. Claire Church.
Hi, morning. I'm Claire Church. I'm respiratory specialist nurse that works with Linny Bush. We're based at Keyworth, and we cover the Rushcliffe area. So we just work in Rushcliffe, and I have used Air Liquide a little bit because I'm part-time, and that's it really.
Thank you. So you have used the Air Liquide portal?
Yes.
Yeah, lovely. Thank you. Next, oh, Caroline has put her hand up.
Hi, sorry, I was here. I don't know why it said that I'd gone. I was here. My name's Caroline. I work at Nottingham City Hospital. I'm one of the COPD specialist nurses. I didn't get access to the Air Liquide portal, and on your portal, I'm a HOOF. It says that I'm HOOF A, but I'm actually a HOOF B prescriber. I'm just waiting for access for that. So that's it. That's me, really.
Oh, thanks, Caroline. Lynn, did you put your hand up as well?
Yeah, I did. Sorry, I forgot to say that I am using the Air Liquide portal.
Thank you. Okay, brilliant. Harriet.
Hiya, I'm here with my colleague Gavin. We're from the Impact Plus team, which is the Derbyshire Erewash integrated adult respiratory team. So I'm fairly new to oxygen. I didn't have access to an Air Liquide portal. Gavin's done it a bit longer and he didn't either, but we've been doing the HOOF Bs. Yeah. So
You did part B. Okay, lovely. Thank you. Who have we got next? Debbie.
Hi, I'm Debbie Hollier. I'm lead respiratory nurse for PICS covering Nottingham West, and we do have access to Air Liquide portal.
Hi, Debbie.
Hiya.
And then Helen, you're next.
Hi, I'm one of the Rushcliffe respiratory specialist nurses, so I work for Nottinghamshire Healthcare. I work with Linny and Claire Church. I cover the north side of Rushcliffe, so there's 4 or 5 practices I cover, and I've used the Air Liquide portal, but not for a very long time. And that's it. There's three specialist nurses in Rushcliffe, myself, Liz and Claire. So yeah, that's it.
Oh, thank you. Okay, where am I up to on my list? Karen.
Hi, I'm Karen Mealy. I work for PICS, same as Debbie Hollier. Cover Nottingham West GPs, and I'm respiratory nurse, but the lead oxygen nurse as well. Thank you.
Oh, lovely, thank you. Adele.
Hi, yeah, I'm Adele. I'm one of the respiratory nurses for Notts Healthcare. I cover Newark and Sherwood, kind of doing respiratory visits, but also doing oxygen clinics and oxygen home visits. And I have been using the Air Liquide portal for a little while.
Oh, great, thank you. Lindsay.
Hi, yeah, Lindsay Hemingway and Fran Corton. We're cystic fibrosis specialist nurses at Nottingham City Hospital. We don't do lots of prescribing, but we do need to have it on our books to do as and when needed. Didn't have much to do with the portal previously, mainly it was handwritten hoops that we'd done. So it's been a while since we've done a full hoop. So, yes.
Okay, and would you normally do part A or part B prescribing?
Part B.
Okay, thank you. Next, Sue.
Hi, I'm Sue McLeod. I'm a respiratory nurse specialist in Lincoln, working with Lincolnshire Community Health Services, NHS Trust. We provide the home oxygen service in the community. I've been using the Air Liquide portal for quite a while.
Lovely, thank you, Sue. Oh, I think it was two Sue. Sorry, I've got another Sue as well, Sue Smith.
Oh, there you go.
Do you want me to come on now?
Yeah, you can do, Sue. Sorry.
Yeah. Sue Smith. I'm advanced care lead for Impact Plus in Derby, covering Derbyshire and Erewash and some parts of Staffordshire. Been oxygen nurse forever and a day, and used to use the portal occasionally. Very rarely in Derby did we use Early Keys portal. We predominantly used a hoof that was linked to System 1 for us. So yeah, Part B prescriber.
Okay, lovely. So that'll be a bit of a change using the portal all the time.
Yeah.
Okay, thank you. Tamara, you're showing up next on my list.
Hi, I'm Tamara Miniken. I'm a respiratory nurse for the Lincoln Northwest team. I do have access to the portal, but I'm very new to prescribing of oxygen.
Okay, so just in general, you're new to prescribing oxygen.
Yeah, I've only been in post a year now, so.
Oh, lovely. Thank you for that, Tamara. Then we've got Joanne Mortimer.
Hi, I'm Jo Baltimore. I work for the Newark and Sherwood respiratory team, oxygen team. I'm an assistant respiratory practitioner, and I am aware of the portal and everything.
Okay, lovely. Thank you. Gavin, were you with Harriet?
I was with Harriet, yeah, one of the respiratory specialist nurses in Derby, working for Impact Plus.
Lovely, thank you.
Thank you.
And then I think finally we've got Jackie.
Hi, yeah, I'm Jackie Truman. I'm a respiratory nurse in Lincoln. I work alongside Sue and Tamara, and as Sue said, we provide the home oxygen service in the community and work alongside our colleagues in acute care in the hospital. And I've been using the portal for a long time.
Oh, okay, lovely, great, thank you. I'm sorry, I said that you were the last, but I've got Bryony. I'm sorry, you were at the bottom there.
I thought I got away with it. I'm Bryony Warren, respiratory nurse specialist and home oxygen service lead for Newark and Sherwood. A lot of familiar names on here might have known me from my previous role. And I used to work with Claire Roof as well. Yes, I do use Early Keys portal quite a bit.
Okay. Familiar, good.
Okay.
Thank you.
Thank you, everybody. Had we all been in a room together, that would have taken probably 10-15 minutes, or we would have meted and greeted as you arrived. So yeah, thank you for taking the time to do that. And as I said, we would have loved to have been able to meet you in person to deliver this session, but COVID has put pay to that. So instead, we have to resort to this remote webinar format, and we really appreciate that this approach is less engaging for you, although maybe you prefer that. But we hope that you still find it useful and interesting. There will, however, still be opportunities for you to engage with us. You can send us a question at any time using the conversation function, which is indicated on the slide now by the arrow. And we'll also have breaks for limited number of questions between each topic section of this webinar. Any questions that we can't answer today because of time, or we don't have an answer immediately, we'll cover in a document that we'll get out to you after the session. Just a few housekeeping points to help the session run smoothly. Please, if you can keep your microphones on mute, so to avoid the distraction of background noise if you have calls coming in. Have your cameras on or off throughout this as you prefer. Please note we are recording the session, so you'll receive the recording after the session. Feel free to share it with colleagues who are not able to attend this webinar or future ones, or you may choose to watch it again. You never know, it may be that good. Yeah, those are sort of the general housekeeping points that we wanted to highlight to you. But let's move on with the agenda, and we'll start with a quick overview of BOC and BOC's home oxygen service for those of you who are not familiar with us. So BOC has a long history in the home oxygen service. We've been a provider since the home oxygen service started in 2006. We have a track record even, of delivering a quality, patient-focused caring service for our patients, and a track record of innovation to improve patient safety and support prescribers. So it was BOC that developed the fire brake, which is now standard mandatory safety requirement in all oxygen installations. And we were the first provider to mandate hoof submission via the portal in our regions, which has all but eliminated the wasted time and the frustration from all parties involved in incomplete and incorrect hoofs. We were really pleased to have been awarded the East Midlands region. We currently serve home oxygen patients in East of England, North East and Northern Ireland. And to give you a sense of scale of BOC's home oxygen service operation today, just for your delight and interest, here are some numbers we'd like to share with you. So we currently serve almost 20,000 oxygen patients across the regions that we mentioned. That sees our patient service centre receive almost 250,000 calls a year. We're responsible for about 75,000 cylinders in patients' homes, and our home care technicians perform 20,000 oxygen installations per year. And in doing all of that, that sees them covering 1.2 million miles on the roads. So as you can see, we are sizably active in home oxygen. We have three core elements, if you like, to our service infrastructure, which all work together, obviously with the patient being the glue and at the centre of everything. So we have our patient service centre. If you happen to have read the service specification or the contract, it's known as the contact centre. We have our team of home care technicians who are on the ground within the region, going into the patients' homes. And we also have our respiratory advisor who works with you and our patients as necessary. So I'm going to hand over now to the team to present their respective elements.
Hello, it's Claire again here, and I'm going to present some of the slides on behalf of Niall, who's, as he said, caught up with communication works at one of the depots. So our home care technicians, you'll be reassured to know that the technicians aren't changing. So the familiar bond and the friendly face patients have experienced during the air leakage years will continue. But to just emphasise BOC's approach to our technicians, we see them as our eyes and ears, and we really invest a lot of training and time to ensure that empathy is at the forefront of everything that they do. So any future technicians are really selected and trained to understand the complex requirement of patients. And certainly over the years, I think all technicians would verify that we're seeing more and more complex needs of patients, whether that be more and more patients are cared for at home with dementia or just complex disabilities and comorbidities as well. Our technicians need to be resilient and to deliver under really testing circumstances. And there's lots of additional coaching from seniors and from overall managers such as Niall, and also through the clinical input of myself and the respiratory advisor as well. So they are trained to have a keen eye for safety, and we really want them to take real pride in everything they do. For a BOC contract moving forward, we're going to be based out of 3 branches across East Midlands region, so we can feed across the area really well. Thank you, Claire.
Thank you.
So we're really pleased to announce that Julie Owens will continue to be the respiratory advisor for the region. So some of you will have met her before, but for those who don't know of Julie, she brings a wealth of experience, having worked as a HOSIAR, a specialist respiratory nurse before, as well as many other nursing roles. So Julie will be really targeting prescriber training, offering guidance on equipment choice, also attending any MDTs for complex patient cases, and working on initiatives to improve concordance, prescribing practice, or patient wellbeing. This is looking at our make every contact count approach. I think ideally it would be really good for Julie to attend HOSIAR meetings monthly or 2 monthly, and whether this is the last kind of 20 minutes of all of your meetings, it will ensure that we're listening to the transition and how it is for you all, and you're really getting embedded with BOC and us, so getting really used to us. And then moving forward, when we're in steady state, maybe it will work that she joins 6 monthly into your team meetings as well. Julie will also contribute to patient and prescriber newsletters for you all, so it's going to be an exciting journey for Julie. Thank you.
Hazel, you're on mute.
I knew I'd do that. Sorry. Hi, it's Hazel. The Patient Service Centre is based up in Worsley, and we're very proud of the PSC. It's basically the main point of contact for patients and prescribers. The photo of our PSC building there was taken on a rare sunny day. And for those of you that know Manchester, it's not always like that. Our team does consist of a number of team leaders. We've got patient service advisors, we've got some admin staff, a couple of analysts, and a quality coach. And between the team, we've got many years experience, and patient care is fundamentally at the heart of everything that we do. We want to make sure that patients and clinicians have a really good experience. The team start the journey really with taking receipt of hoofs and contact patients, carers to complete DBRAs, and then they arrange the installations. We're available to process replenishment orders for patients and provide troubleshooting for the equipment as well as for the portal. So there is a number of options to get through to the PSC. So we have email addresses that you can see on the screen. If you go onto the website or if you're in the portal, there's an option to communicate via live chat with us as well, or you can give us a call. So we have two 0800 numbers. One's for the patient, and then we have a new one, which is on the screen, which will be live in the next few days, which will be for clinicians to contact us. And then just kind of in a high level, really, in terms of the journey that the hoof will take, I just wanted to kind of explain that the PSC here manage the process really from the hoof coming through. We validate that everything's okay with that. We do the desk-based risk assessment, and that gets handed over to the technicians. And then once the patient's been fully installed and aware of what they're doing, they can just reorder and replenish directly with us, either over the phone or they can use the portal. And then the loop gets completed in terms of every 6 months to visit the patient to do equipment checks and services and risk assessments. So the big change really for you guys in terms of that whole process is the very beginning piece with regards to submitting the hoof through the portal. Claire, just before I introduce Joe, I've got Vicky that's the team leader from the PSC on the call. Is it okay if Vicky just says hello quickly?
Yeah.
Morning all. I'm
just want to say hello, and I'm really looking forward to working with you all. As Hazel said, there's a few team leads at the Patient Service Centre, so if you do need anything, one of us is always on duty, ready to help out. So just let us know what you need and when. Thank you.
Thanks, Vicky.
Okay, so thank you all. So we'll move on to the main topic of the day, what you've all been waiting for. So our home oxygen portal. So over to you, Joe.
Thank you very much, Claire. Very good morning to you all. I hope you're all doing well and hope you're all staying safe and healthy despite the current circumstances. I'm Joe Dillon, and I'm going to take you through the portal today. So just a couple of quick things about myself. I'm one of 2 data analysts for BOC Home Care, and my role is to provide, as I mentioned before, both structured and ad hoc reporting. So I do certain scheduled reports every month, and I do ad hoc requests that come in. But most personally, for our purposes here today, I am going to be the main point of contact and expert for the BOC Home Oxygen Portal. And why, yes, I can assure you that is the most flattering picture of me that I could find. So moving on, let me tell you about what the portal can do. So the first thing is your bread and butter, the hoofs. You will be able to submit hoofs online through the portal, and you'll be able to do that in a very quick and easy way. Additionally, the portal also includes automatic error checking. So let's say, for example, you're creating a hoof and you completely by accident, because it happens to the best of us, you forget the patient's telephone number. At that point, you're filling that in on the hoof. The portal will let you know that you've missed that out, and it will not allow you to proceed. So those kind of mistakes will be eliminated entirely. You can also, while you're on the portal, use what's called the patient dashboard. This allows you to view a patient's previous usage, their current holdings, current prescription, their address, if they have any safety alerts, and other details as well. And that's updated daily, so you get to see that in pretty much real time. Now, as you go along through using the portal, you'll build up a library of hoofs that you have submitted, and you may very well wish to retrieve them at a later point, maybe to have a clinical discussion with your colleagues to upload to System 1 or a similar NHS system. And for that, we have a hoof archive. You can access your hoofs from there and download them as a PDF or Word document format. Additionally, because I know that a lot of you work in groups together as HOSEAR services, we can also create what are called prescribing groups. These allow you to link together with other users of the portal, and through that, you can view their hoofs. So normally you would only be able to view your own on the hoof archive, and same for other users. But if you do need to share hoofs, we can set these up on demand. But we may also, you may also wish to then send a removal through for a patient. If, for example, it's a neonatal patient, they no longer require oxygen, you can send that through to us via the portal, and it's a much simplified process versus actually doing a hoof. You simply fill out the patient's demographic details, the reason why, and send it through to us. And regrettably, from time to time, as no doubt you've seen firsthand, we can have instances where patients may end up, for example, suffering a trip or fall, or may be found to be smoking unsafely. And we have a specialized interface for you to send those details through to us to inform us of safety incidents like that, and these are responded to promptly. And last but not least, we also provide resources of various types on the portal for you to access at any time. These can include things like video guides, and we can also provide safety information, newsletters, and what will be discussed later in this presentation, the modality selection tool. They're all available there for you. So I'm going to take you through how the portal looks and how you register. The actual registration process is dead simple. You simply go to www.bochealthcare.co.uk/HOP, and you click register here, as you can see on that screenshot. There is an alternative web address that's shorter and easy to remember, which I will give to you now as well, www.bochop.co.uk. Now, if you want any of these web addresses at a later point, you are more than welcome to ask me, and I will provide them for you, no problem. That main page that I mentioned is also where you can reset your password, because again, it happens. I forget my passwords all the time for various things like Netflix, Amazon, you name it. We're only human, so you can always reset your password there. Definitely make sure to bookmark this page when you get the opportunity. So the portal is a one-stop point for both patients and clinicians. We have patients, for example, who log in and order quite frequently through there, or they notify us of things like holiday requests. For our purposes for this demonstration, though, I'm going to show you how to register as a clinician, and you quite simply click register as clinician. So this next page is a registration form, and the image that's on your screen now is just some of the fields that are on there that you have to complete. Any that are marked with a red asterisk are mandatory. And I've just got a couple of notes here that will also tie into what was discussed previously. I think it was Linny that brought it up. I apologise, by the way, if I'm mispronouncing your name there, Linny. We can only accept registrations from @nhs.net addresses or those that meet DCB 1596 accreditation. I can't even remember what that is offhand myself. So if you're unsure if your email meets this standard, I am more than happy for you to contact me at the email address we gave earlier, which was boc.hop@nhs.net. That will be available at the end of this presentation as well for you to take down. And I can certainly advise you, give you the necessary links to make sure that you're up to that standard. I should also mention you must be using your own email address and not share your account with anyone. We cannot accept generic group emails. We will also we will also require a professional registration code, and that'll be in most cases for yourselves, your National Medical Council, your nursing register PIN. It can also be a GMC number or any other appropriate professional registration code. Now, your access to Part A and Part B prescribing is determined by your role. If you have any concerns about what role you have been given, just contact us and we'll take that further as appropriate. So once your registration is actually done, once you fill it out completely and sent it through to us, we're going to vet it against the appropriate professional register, and then you'll get an email link to provide a password and a security question. And that is done within 30 minutes, and that's any time of the day. So once all that's then done, you've got your password and your security question set, you can log in and start prescribing immediately. There's no like cool down period or anything like that. You can go right into it. Speaking of which, you can log in again from the same web address, bochealthcare.co.uk/hop or bochp.co.uk. Now, this again ties into, I think, something Linny brought up before, which was regarding IP addresses. You may be asked to verify your IP address when you log in. And I apologize if you've already encountered this firsthand, but just so everyone's clear, what this will involve is you will be sent a link to your registered email address to confirm that it's you trying to log in. This is something that's called two-factor authentication, and it's essentially a security measure because let's hypothetically say somehow a certain individual, an unscrupulous one, has obtained your email and your password and tries to log into the portal. They could very well be in a different part of the world. Speaking from my own experience, someone actually in Brazil tried to log into my Netflix account once, and it did something similar to this, where it asked me to verify it was me. Not being in Brazil at the time, I did not, of course. So you just click that link and it'll confirm that it's you, and then you can log in as normal. Now, I should note as well, just to follow up from what Linny said before, to just cover everything for people who might have arrived late, you may get asked to verify multiple times, and that's because your IP address can change depending on where you're logged into. If you, for example, switch between different access points in a hospital, if you work from home and then move to a different place, it could even change during the day, for example. So it may ask you multiple times to do that. You may wish to look into getting what's called a static IP address. I'll not go into detail about that now, but if you do want more info on how to do that, again, just feel free to contact me by email and I'll take you through the necessary steps on what to do. And lastly, I'll note that you do only have a certain number of attempts when logging in, just in case you get your password wrong. Again, it happens to the best of us. If you have any difficulty logging in, you're also again more than welcome to contact us via phone or email. So once you've logged in, you'll be presented with the hoof overview page, which looks like this. And from here, you can track the progress of any hoofs and removals you've submitted as BOC processes them. So initially, they will start on the left, depending on what time frame you've submitted. So it could be urgent, next day or standard. And then they will move along to the right to accepted and then disappear entirely when done. But since we're creating a new hoof in this demonstration, we will click Create New Hoof. So of course, we need to envision a patient that we're going to prescribe for here, and I have just the person. This is a gentleman named James, who is a 65-year-old male who suffers from COPD. Now, he's currently in hospital and awaiting discharge home, and we want to get him out there to, free up bed capacity, get him home, make him comfortable. Just for the purposes of this scenario, James has been tested for COVID-19 and his results are negative, and we will be arranging for him to have a static concentrator and standard ambulatory cylinders. Now, just as I mentioned here, this is just for a fictional patient and is just for illustrative purposes only. We will be covering later in this presentation about how best to decide what a patient should have, but this is just strictly, as I say, illustrative, and just use your own discretion for any patient may require, of course. So when we're actually creating a hoof and you've clicked that button, you'll be taken to this first page. Now, I recall from that some of you have mentioned that you're mostly familiar with the paper hoof. And what I want to reassure you of here is that we've structured the process of creating a hoof on the portal to be section by section in line with the paper hoof. So the first part of the hoof creation process is section 1 of the hoof, which is your patient demographics. Section 2 is GP information. Section 3 assessment. It's segmented that way to be as easy as possible for people who've not really used an online portal before, be it our own or Air Liquide's, and instead are more familiar with the paper hoof. So COVID-19 status needs to be completed with each hoof. We don't assume that from a previous hoofs that it's still the same just because with the ongoing situation. And all fields, again, marked with a red asterisk are mandatory. So one thing that you will know is that there is a box for NHS number and date of birth. When you fill these out, it will actually query the NHS Spine service. And if a match is found based on NHS number or DOB as a combination, you'll get given their demographic data automatically. So their name, their address, those kind of things. That'll be filled in for you, saves you having to type it out. This is additionally the case if the patient is known to BOC previously. So if when you, for example, go live on the first day, we will, of course, have all of the existing patient data on the portal. If you were then to prescribe for a patient you have done so far in the past, their demographic details will appear automatically. It saves you having to type them out again. In the case that the patient is brand new and the oxygen and is not on the spine, you would need to provide their information as a first time round. But then, of course, it would be available later and would also fill in the same manner. So on this screenshot now, we've completed James's information for part 1. So this is just his address, his name, his date of birth, his telephone number, and so forth. So all of these fields, except for the COVID-19 one, are ones already on the hoof. And so if you create an electronic copy of the hoof for later use as a PDF or a Word document, these fields will map automatically to the appropriate fields on the electronic copy. And to continue, we can just click Save and Proceed, which is at the bottom of the screen. It's not showing the screenshot just because of size, but it is there. If you miss any mandatory fields, it's at this point the portal will tell you you've missed one and it'll tell you what's missing. And let's say, for example, you complete this section just fine, you filled out all the fields, but you may, for example, have missed a digit off the patient's phone number or got that wrong. Again, it happens to the best of us. You can always come back to this point by clicking the back button on the bottom of the page. That will take you back to this point, and you can simply just correct it and return to where you were previously. So page 2 is where you provide the patient's GP information, their clinical code, if they're on an NIV or CPAP, and also their pediatric status, if it's an order for someone under the age of 16. For GP practice, you may very well be prescribing for a patient who has their registered practice at a satellite surgery. So you've got 3 surgeries in the same campus or building. That happens. So when you put in the postcode for the GP surgery here, it will give you a drop-down menu, and this allows you to pick which surgery you want, and that will then autofill the surgery details for you. You don't need to type them in manually at all. And so with this bit done, we can now click Save and Proceed. But as before, if we want to go back and amend section 1, we can just click back to do so. So the next page is part 3, where we can provide the details of the hospital or community assessment service, etc., that's been caring for this patient, as well as ward details if appropriate. Now, the same as on the actual hoof, this page is entirely optional, but it can be useful to fill it out in the event that we need to contact someone other than yourselves regarding the patient. If, for example, you have to go elsewhere if you end your shift and someone else is taking over care, it can be handy to have an additional contact point just in case you need to pick something up. But otherwise, we've done this bit, so we're going to click Save and Proceed. So this is the interesting part. This is where we get to pick what modalities James is going to get. We've already determined for him that he's going to need a standard concentrator and standard ambulatory cylinders in this scenario. But before we begin prescribing, we should discuss modality selection and how to pick the best treatment for your patients. What I will mention is that if you are a Part A prescriber, you will be limited to prescribing static concentrators, static cylinders, and in very specific cases, standard ambulatory cylinders only. If the patient needs other modalities, please refer them for the appropriate respiratory assessment. Otherwise, that takes us to the end of this segment. Thank you very much for your patience and time with that. Do any of you have any questions or anything you would like to ask at this point? Please feel free to raise your hand virtually, and I'll be more than happy to go through them with you. Okay, I see we've got a couple of people putting their hands up here. I'm going to go through them in order. I'll start with Jackie Truman.
Oh, hi. Yeah, I don't know if it's been rectified, but when I registered on the BOC portal, I think the drop-down box came, it's a bit, I put respiratory nurse, but then it only allowed me part A. I just wondered why. What,
Okay, we provide Part A, Part B based on role. It may very well be that the role you intended to pick wasn't there at the time. What would your role otherwise normally be? What's the best way to describe it?
I'm a respiratory nurse specialist.
Right, okay. What we'll do then, Jackie, I will speak to you after the meeting about that separately and we'll get that resolved for you. Will that be okay?
Yeah, that's great. Thank you.
Wonderful.
I think that also comes from the roles and the permissions that Wendy Bradford, the regional clinical lead, has asked us to set up. So she has defined roles and whether by default they're Part A or Part B. The Part Bs, I can't remember off the top of my head, but they there's an oxygen nurse, HOS-AR lead, I believe, in the drop down. So I know this sounds weird, but it's less about your actual job title and more whether you are a specialist oxygen prescriber within your service. So it's probably that had you selected oxygen nurse, that would have granted you that Part B automatically.
Yeah, I think that was the problem. There wasn't clarity. So obviously there wasn't respiratory nurse specialist, although we provide the oxygen service. So it's just making sure that I can do Part Bs because that's part of our role.
Certainly. We'll make sure to take care of that after the meeting concludes for you there, Jackie. It's a very quick fix to solve.
Yeah, I think one of my colleagues in another.
Well.
Yeah, I think it's been a problem across. I think we've all pressed the same button and we haven't been able to do it.
Sorry, who was that who spoke up then asking?
Sue McLeod, I work with Jackie.
Ah, hi there, Sue. Yep, similarly, we'll resolve that for you after the meeting, no problem.
Okay.
I think it's happened as well. Sorry, it's Hazel here. If the clinical lead for your kind of CCG or your area kind of confirms that you can have a Part B, then we just organise it and we just switch your role over. It's really quick to do.
Absolutely.
So I did email all the clinical leads and just let them know that they might receive some emails from their team saying that they need access to Part B and just to reply to us, and then we'll arrange it for them.
Absolutely. Right, I believe the next person to ask is Linny, and I apologise again, Linny, if I'm getting your name wrong there. I hope I've got it right.
No, it's right. It's fine.
Excellent.
Thank you.
Excellent.
Just a question about the patients using the portal to order their own refills.
Mm-hmm.
What training will they receive? Is that just going to be on a pamphlet? Are we expected to talk them through it, or will they get training from the technicians?
What we would do is we provide them with a link to the portal to register, and there is actually a video library that I mentioned before that is available also for patients, and there is actually a guide on there for them to demonstrate how they use their side of the portal and how they order through it, and there will also be, I believe, some written material for that as well.
Okay, thank you. But obviously they'll still have the option to ring in if they don't have IT access.
Yep.
Yeah, okay, thank you.
Excellent. And I believe finally, based on number of hands we have up here, it's Lindsay Hemingway.
Yeah, just to say we've got the same problem here. We've registered as specialist nurses and it's put us as Part A. We need Part B as well. So we'll see if nurses in Nottingham. And just to clarify, when we've done a group online, is there a way of downloading it so we can register it on our digital health records?
Do you mean once the HOOF has been created and submitted, how you would then save it to upload to that system?
Yes.
There is. That is
Yes.
actually demonstrated later in this presentation.
Okay, brilliant.
So we'll
Thank you.
No problem. And just again to reassure you, Lindsay, we'll sort out the role issue for you as well after the meeting concludes.
Thank you very much.
And finally, I think we've got one last one here that's popped up. Sue, Sue McLeod, I believe. Sue McLeod, sorry, I mean to say.
Yeah, sorry. It's just regarding kind of your COVID-19, really. In the drop down, does it just say positive or negative? Because I'm just kind of conscious that some of our patients may not know.
Yeah,
You know,
would it be?
that's an
I
issue,
mean,
really.
yeah, that is 100% the issue with COVID. We have 4 options on there. We have confirmed positive, confirmed negative, suspected, and no symptoms.
Right.
I would, just as a hint, if you are awaiting the results of a swab test, because with the current situation with testing being what it is, I would put down that they are suspected. This is just to inform our process for installing patients' homes with the appropriate PPE and precautions given the current COVID-19 situation. If you're in any doubt, go with that, I would argue. But yes, there is a level of granularity there.
Right, okay, that's fine.
Superb. I believe based on the lack of hands in the chat that is the end of it. But if anyone does have any questions that might pops up, do feel free to do so now before we move on. No, it looks like we're good. Very excellent. I'm going to pass it now back over to Claire Murphy, who will take you through the modality selection tool.
Okay, so just give us a few moments while we change screens. Hazel, you're going to bring up the modality selection tool.
Just while we're transferring screens across, just to say that Anna Evans from Chesterfield Royal Hospital doesn't have a mic, but she has put up a question about Part A prescribers and ambulatory oxygen. Just to clarify, we don't allow them to prescribe ambulatory oxygen as such. What we do facilitate is in situations where it may be a palliative prescription and we've got a patient going to the hospice, or for an outpatient follow-up, we would allow 1 cylinder to be prescribed by them. So it's not ambulatory oxygen as such, it's just to enable those appointments to take place. But now when we move to the role of the modality selection tool, so we all know that when we're looking at long-term oxygen therapy, anything over 3 hours requirement needs a concentrator. So the positioning of the modality selection tool is for you to look at ambulatory provision and what's best suited for your patients. So first of all, what you would need to do is to select if your consumable was to be a face mask or nasal specs. And this also helps us with conserving capabilities in our modalities. And I'd suggest, particularly for those people on the call who said they're quite new to prescribing or haven't used portals before, it's worthwhile using this tool. So for example, Claire, if you could, or Hazel, if you could please input for me nasal specs. So we'll do a trial here, nasal specs, 2 litres a minute for 4 hours a day. And let's see what it brings up for us. So here you can see priority is given to what is the most cost-effective and sustainable option. So here we've got the portable concentrator, followed by my either liquid oxygen, and then we move to cylinders. So this is really directing you, and thank you, can support your prescribing and what is best suited to trial with the patient as well. So if we now just trial something like, can we have nasal cannula again, 4 litres a minute on 6 hours a day, but this time we're going to look at some lifestyle options as well. So if we could tick a secondary address and frequent short breaks, please. And here we can see now the options have slightly changed and is now considering a transportable concentrator to be the most cost effective and sustainable modality for you to trial. So I would welcome some feedback. Use the modality selection tool and see how it aids your prescribing and supports your decision making, especially for those that are new to the oxygen world as well. Thank you.
Okay, so finished on that section, Claire?
Yeah, unless anybody wanted to give me something to put in there, or is everyone happy with the tool and how to use it? It's very straightforward. Sue Smith, what would you like to say or ask?
So just the query that we could possibly have around the cluster headaches I saw on that little box. Do they automatically get the Schrader valve, or is it dependent?
So at the moment, part of the new contract for East Midlands is that we will be delivering the demand valve. Now, locally, the pathway is being worked on by Wendy Bradford and a neurologist, so I'm not clear what the criteria is. Looking at how we deliver this in the east of England and the northeast, you go for the demand valve. As you know, when a patient is going to be trialled on oxygen, then we recommend that you trial the oxygen with the demand valve. For so many reasons, because it conserves the oxygen, so it reduces the amount of cylinders they may need, reduces emergency call-outs, and most importantly, it has a better benefit and effect for the patient who's going through that cycle. So
just to jump in there, at the moment, Wendy and Priya are saying that the demand valve won't be available via the hoof until that pathway is in place. So we're waiting for that to be progressed, and I think as and when you have a patient where it could be where it's relevant and beneficial, that at the moment would have to be escalated to Wendy and Priya for them to pursue the approvals before that pathway is in place.
And I know that we've had, I think someone else I was talking to, one of the clinicians was saying that there was a patient who has been aware of the demand valve for some time and was really escalating the need as a complaint. So whilst Claire said it's not available right now, with those particular patients, I'd urge you to talk to me and we'll talk to Wendy and Priya to see how we can expedite this for you, because we have them ready as well. Linny, you just wanted to ask a question?
I do, yeah. Do you supply the mouthpiece sets to accompany the shoulder valves?
Yes.
Demand.
So, yeah.
Are they audible on the hoof then? Is that one of the options for consumables?
I need to check actually. Joe, is it on the hoof, on the portal?
It is not, because there is no field appropriate for that on the pay-proof for that. What I would ask is that if you want a demand valve, there is a section that I'll be covering later for additional patient information, and you just write demand valve in there, and then we would provide.
And mouthpiece, yeah.
I believe, yep.
No, you don't need the mouthpiece, Linny. It's just as if you put demand valve, it will come automatically with the mouthpiece, and we then replace the mouthpiece as well.
That's great, thank you.
So in the future, it will become more of a kind of normal prescribing. We're just waiting for some final agreements to be ironed out with pathways.
Great, thank you.
So if there's no more questions, we can move on from the modality selection tool.
Okay, thank you. So now we'll move on to equipment that's new to the East Midlands, which Niall would have been covering if BT hadn't planted the appointment today. So Claire, you're going to cover for him again.
He owes me one. So looking at...
Sorry, Claire, your screen, you need to change it to full screen.
Apologies. Thank you, Hazel.
So I've spoken to some of you with some introduction meetings and introduced some of the equipment that we're bringing in. So what we can see here on the screen and what I'm about to cover are the new devices, what's going to change over time, the Everflow concentrator, the Inogen G5, and then just our cylinders that will be brought in as well. Thank you.
Sorry, hang on.
So here we've got our Everflow static concentrator. Now, Air Liquide already have supply of these from us with the aim that they should be installing the Everflow at every opportunity alongside the Inogen G5 portable concentrator. So they're swapping out their equipment with ours. And when we come into the region, we'll be doing this at a faster pace as well. But here on the screen, you can just see some details of the Everflow, and it's highly rated because it's considerably quieter. So that's a big plus for our patients. Smaller and compact in size, uses less electricity, although patients get the electricity refunded, and it's very, very reliable. There isn't a filter to wash or replace externally. We just need to keep the vents dust free. And just to note here that the there is some areas I know within East Midlands where there's been a transportable concentrator that's been put in due to property sizes and complaints from a patient about noise. So the aim now is for all of those TOC patients who have the TOC in place and being used as LTOT, that they really should be transferred over to the Everflow because of its size being smaller and it's quieter. And this is the far more sustainable and cost-effective modality for LTOT, just to reiterate again. Thank you. That was a question. Bryony, do you want to ask a question now?
Sorry, just a quick one. What did you say the weight was of the Everflow?
Can you go back a moment there, Claire?
I can see the dimensions, but there isn't weight.
We'll get that to you after.
Thank
That's
you.
okay. We'll
Thanks.
add it to this for the future.
Yeah. So here we've got the range of portable concentrators, and I think within East Midlands you're familiar with the G2 and the G3, and now I'm really pleased that we've got the G5 to introduce, because this widens the availability for a bigger patient cohort to have what is effectively more of a handbag size oxygen delivery system, which is much more discreet as well. So it goes up to settings pulse mode of 1 to 6, and the battery duration, if you compare that to the G2, is nearly double. The charge time is 3 hours and the weight is significantly lighter. But let's just look at the battery for the moment. So the G5 will be issued with an 8-cell battery, but the new contract actually specifies that only one battery is to be given to a patient. So if you've got any patients wanting 2 batteries, we just would need CCG approval for the larger 16-cell battery. So that's just to make you aware of that. But the G5 is really exciting and brand new for the region, so we're excited about this one. Thank you. Bryony, is there a question still? No, Linny, you've got a question? No, just your hand up, that's fine.
Yeah, I've just forgotten to lower it.
So here on the screen now, we've got our static cylinders, our big ZH cylinders. So primarily these are used as emergency backup should there be a power cut. So with every concentrator install, this will automatically be provided. You don't need to select it on the portal. And then the other patients that would have ZH cylinders installed would be for cluster headaches, where they're using either the non-rebreathe bag or the demand valve as they should. And you can see the dimensions on the screen. The one thing that I always say to clinicians is to make sure that you can see this when you're doing any house visits, because often we can find they're quite big and ugly and people put them under the stairs or in the shed, and when there's a power cut at 2 in the morning, they can't get hold of them. So yes, we've seen actually, I've seen a picture of a patient wrap a plant around it, like a vine plant around it, which looked really good. So next slide, please. And then we've got our portable cylinders. So we supply a range of CDs to DDs to ZA, and the main thing is the flow rate in what they deliver here. So the ZA is the smallest cylinder, and it's still targeted more for pediatrics or for those that really can't manage anything else. But I'd urge you all to really be mindful of what flow you need in and whether that's better suited by a different modality. So go back to the selection tool and think about portable concentrator, liquid oxygen, having a flask that's much lighter and smaller, and just looking at about that sustainability element as well. But that's the range of cylinders that will be in East Midlands. Thank you. Any questions at all on the equipment that's coming in? Jackie, how can I help?
Yeah, will you be covering conservers? What conservers will be available?
Oh, good question. Have we got Niall here? We have got the conservers. I'm not so sure on the specifications for East Midlands. Or Claire, are you aware?
No, we haven't prepared. It's a learning point for the next one. We'll add conserver information to this and get something out to you all separately after this. So we'll be taking on the Air Liquide existing conservers for a period of time, and bringing in our own newer. I recall that we will have the same models but newer versions of some of Air Liquide's equipment. But we'll get something out to you separately.
Good question.
Yeah, add it to future versions of this. Thank you.
Okay, Linny, do you have your hand up?
I do, yeah. I didn't take note of the Everflow. Does it do low flow settings, or is there another low flow version of it? So to do 0.5 increments?
Yes, it does. Claire, can you go back to that at all?
I can.
So we've got lower flows of 0.1.
Sorry, no.
Yeah.
Do you mind if I just take a shot of that screen? I'm just taking photographs. Hang on. Thank you. Right, that's me. Thanks.
We can share.
We'll send this to you afterwards.
Yeah.
It'll be available on portal. Another incentive for you to
sign up. Yeah. Bryony, how can I help?
Hi, sorry, what about high flow concentrators?
Yes, so high flow concentrators will be coming in. So when I've been in the east of England, I've lived the Eastern England world and the Northeast world where we deliver up to 10 litres. So I wasn't aware that you had only up to 8 until I started speaking to you clinicians. So high flow concentrators up to 10 will be available for you, and the ability to piggyback them together as well when needed. Does that answer, Bryony?
It does. Sorry, so I know I might be digressing a bit. So this was regarding the email that I sent. So I know that we were supposed to contact regarding our assessment services to ask the replacement of our equipment. So both of our sites have high flow concentrators in place, and at the moment Air Liquide said that you're not exchanging them. So do you have a idea or pathway about what's going to happen with exchanging those?
Claire.
Yeah, Bryony, what Air Liquide are doing at the moment is, as Claire mentioned, they are swapping in those specific models that we've already provided them with, because we'd already received the deliveries from the manufacturer before COVID impacted, and we believe it was the area of their existing equipment that needed the quickest change out because of the age of the equipment. So they've got Everflows to do static concentrator change out. They've got the Inogen G5 to change out the older Inogens that they have. And for new installs, any new installs, they should be using our equipment. And we've also provided them with a number of new Sequoia Eclipses. Everything else that's in situ with patients today, we're taking on and over. So if a high flow concentrator is there, the high flow concentrator remains in situ, and over time we will, as we need to visit that piece of equipment because of a technical issue, we'll swap it out for our equivalent, or as we're doing servicing visits, we'll and other any opportunity we'll be trying to swap in our other equipment. What we've done on today is just highlight those things that are different, because some of the models we use the same thing as them. We use the G3. We use the same high flow or some of the same high flow concentrators, so we focus more on the things that are new. But over time, anything that's in situ with patients will be changed out over time. I can't give you a time frame for everything. It will be as is needed and as we get to those patients.
Okay. I wouldn't imagine, Bryony, it won't be long for you to have it swapped out for your assessment service.
Okay.
No, we prioritise those.
Okay.
Yeah.
Do we need to specifically request on the hoof that we want a high flow concentrator then in an additional information box? Sometimes, for example, specifically our ILD patients, we're often titrating, and we know that their oxygen flow rates are going to increase quite quickly. So we ask for a higher flow one to enable us to do that and continue our assessments.
Yeah, I mean, I think you could put it into additional comments, reasons why. Sometimes, just to make you aware, if at a depot there is any issues with a high flow, they could put 2 lower flows in and piggyback together, and then in a future date swap them out. So I believe there's quite a few high flows coming into your region, but it's always useful if there's any particular reason why you just want one high flow to go in, to put it in the additional comments. But Joe, did you want to add something there?
Yes, I'll be coming to this very next section actually on how you do prescribe various modalities. High flow is not a separate option on the portal, but what we provide is in line with what flow rate you request. So when completing that HOOF for your assessment centre, I would simply put the minimum possible flow rate you would assess at, the maximum possible flow rate you would assess at, and then we'll provide the appropriate equipment to do that. It wouldn't hurt, as well as Claire mentioned, to just put please provide high flow for assessment purposes in the additional patient information section, which I'll be showing off in just a short moment.
Anything else? Thank you, Bryony. Okay, if there's nothing else, we can move on to the next part.
Excellent. Thank you very much for that, Claire. So we're picking up where we left off from before, where we were completing the HOOF for our fictional patient, Mr. James Smith. And so having now gone through the modality selection tool process, we've decided what we're going to give him. So James in this scenario is going to need 2 litres a minute for 16 hours per day on a static concentrator, and is going to require a variable flow of 2 to 4 litres a minute for 4 hours a day on standard ambulatory cylinders, and this will all be with cannula. So when you get to this section on the portal, you will note there is no current option to pick a modality. What you need to decide first is whether or not you're going for standard or variable hours per day. So in this case, since one of these flows is going to be variable, we pick variable from litres per minute. And then on hours per day, since they're both set, they're fixed numbers, we pick standard. So having now picked the flow and hour ranges for our HOOF, this window will then refresh and you'll see these options for modalities. The way we've built this system is a lot like ordering from any basket-based online service, like, for example, Amazon, or even if you say order Domino's, something I'm personally intimately familiar with. You add items one at a time to the basket, and then you submit the HOOF when it is complete. So for the moment, we're going to start by adding a static concentrator, which we will then fill out with 2 litres a minute, 16 hours a day on cannula. So this is what it looks like when it's filled in. You can see additional options have opened up. If, for example, we required a mask for James in this circumstance, we can provide one by clicking on either the 24 or 28% mask options. This only appears because James is on a flow rate that supports these mask types. If he were, for example, on a flat flow rate of 3 litres a minute, it would not show up a mask menu at all. Whereas if, for example, he was on, say, 2 to 10 litres a minute, additional mask options for the higher flow rates would also then appear. But since we're keeping only to cannula, we're going to leave those unselected. I will note as well, just because it was brought before about cluster headache patients, if you pick a minimum flow rate of 10 litres a minute, an option for a non-rebreathe mask will also appear at this point as well. Since we're happy with this, we can click add to order to add the static concentrators to the order now as well. So on the bottom of the screen, you can see now the static concentrator has been added as text, and there is a delete button next to it. This is the point also where we're now going to add the standard ambulatory cylinders. You'll note there are additional options here for low flow, microflow, and conserving device. When you pick those, the flows that you can prescribe change as a result. This is part of the error checking process of the home oxygen portal. So you can't, for example, pick a low flow meter and then request 0.01 because you would need a microflow for that. If you want to delete a specific item from your order, you can do so by clicking delete next to it. Or if you want to start completely fresh, you can click reset and clear basket at the top, after which you can add that again. I mean, again, this happens to all of us. We all make mistakes. So you do have the option to just delete one item if you need to change it, or completely start from the beginning if you need to as well. And so now we've added our standard ambulatory cylinders to the order. You can see it's got 2 litres a minute, 4 litres maximum for 4 hours a day. We're happy with what's going to be given to the patient, so we can progress to the next part of the hoof. This is the point where we can also pick if the patient requires a tracheostomy mask. The option for this, you can see, depending on how good your screens are, is grayed out. And that's because we don't currently have a mask selected for this patient. If you have picked a mask of at least one kind, that will then unlock and you can say yes or no as appropriate. This is also the point where we pick our delivery time frame. So this would be where you decide if it's 3 business days, next calendar day, or urgent 4 hours. Since as part of the scenario, we're going to discharge James on a next day basis, that's what we've picked here. So the final section of the hoof covers temporary supplies, additional patient information, and clinical contact details. Additional patient information is best served for additional clinical information that otherwise cannot go on the hoof. If you want a demand valve, if you would prefer a high flow concentrator, things like that. Temporary supplies, those fields are for you to arrange holiday or respite hoofs for patients if necessary. So if you're, for example, arranging oxygen for a patient to go home with, but they also have a caravan, this would be how you would do that. And you can also use this to arrange different equipment at another address as well. If, for example, they're at a caravan where they simply don't have any power supply to use a static concentrator with. You'll note at the bottom, there is an option for what is called an addendum. The hoof addendum, when you click yes there, will give you a much larger text box, and that allows you to type more long form information that won't fit on the hoof. This, however, is for non-clinical information only. So this, for example, let's say James, he does not speak English as his first language. This would be where you would provide that so we can then make sure we have an interpreter handy. If they're a smoker, if they require high visibility tubing, contextual information like that that can assist us with the installation and contacting of next of kin, that can all go in there. It cannot be clinical information because when you print the digital copy of the hoof later, which I'll be showing in response to a question we had earlier, that information is not transferred there because there's nowhere for it to go on the document. But it's still very useful if you want to provide us with that kind of non-clinical contextual information. But we've done all those fields, so now we can proceed to the review stage. So the review stage, this is where you can look over the hoof in its entirety and make sure everything's absolutely fine. If you again want to make changes at any point, you just click back to return to the appropriate page and make the necessary amendments. What you will also need to do here, and you will not be able to proceed without doing so, is to tick the 2 boxes to confirm that you have filled in the HOCF and the IHORN forms, the home oxygen consent form, the risk mitigation form. If you also want confirmation of installation to be sent to an alternative email address, you can do so at this point as well by filling in a different email on the bottom left there where that field is. And now we can submit the hoof by clicking Create Hoof. So once you've submitted the hoof, you'll receive an email confirmation like the one at the bottom. And at this point, you can also then download the hoof as a PDF or Word document so you can save it to System 1 or EMIS, for example, using the buttons that appear on screen. One thing I should note as well, hoof confirmation emails, we provide these at every stage of like a hoof's life cycle. So when you submit it, when it is accepted, when it is completed, these will only go to the prescriber who submitted the hoof. They will not go to the HOSAR service nominated mailbox. One thing I'll note as well, because of course this ties into how hoofs being for new patients, we will also be providing daily uploads of reports covering new and removed patients as well. These can only be accessed by certain users inside specific reporting groups, which I'll be commenting on in a little bit. But once the hoof's been submitted, you can then track its progress from the hoof overview page that I showed earlier, and you can download it from the hoof archive as well if you need to at a later point. So other features of the portal I'll mention while we're here, we do have a video library, and this is where we gather up videos that are on YouTube that are approved by ourselves, and these can include a number of different topics. We've recently, for example, provided access to the Hands, Face, Space video provided by the government on COVID-19. There are also video guides on how to use the home oxygen portal, narrated by yours truly. There are safety videos as well on home oxygen use, some of which are also narrated by Claire Murphy, and other videos like that as well, slips and falls and awareness and safety training. So you remember that we mentioned before about the modality selection tool. there is a section on the portal called the download section, and this is where we provide files for you to download as clinicians. So this can be things like the modality selection tool we showed off before, or we can provide newsletters, guides on how to use the home oxygen portal, guides on how to import eHoofs into admin systems, things like that. There is also a view-only role. This view-only role is provided to a certain approved users, and it allows access to reports that we upload. These reports are provided in Excel format and can be downloaded to your PC just by clicking on them. They can include things like lists of patients, billing reports, contractual reports on KPI performance, and other things as well. Access to these reports is determined in a number of ways. We align reports to a certain CCG when we upload them. So if you, for example, are in Newark and Sherwood and you have access to Newark and Sherwood reporting, we'll upload reports to the Newark Sherwood CCG. You'll be able to see them, but you will not be able to see reports belonging to other CCGs. But we can also upload them to what are called reporting groups to fine-tune access. So if you have a particular team of people who you want access to a specific report and no one else, we can build that group for you. And we can also give it access on a person-by-person basis as well if necessary. View-only users cannot prescribe oxygen on the home oxygen portal. It is just for downloading reports. This is also the interface where we'll be providing daily uploads of reports that show the new and removed patients I mentioned before. And generally speaking, we'll be going through reports in much more detail on the future webinar as well. Otherwise, that brings us to the end of the section about the home oxygen portal. Thank you very much for listening. I'm going to go through questions in just a moment, but again, if you do have any comments, feedback, issues or queries that come up at a later point, you are more than welcome to email them to boc.hop@nhs.net. I can see that we already actually do have some people who've put up their hands, so I'm going to go in order here. Can I start with Sue McLeod?
Yeah, it's just about urgent verbal hoofs really, because we work in the community and very often we're in patients' houses, and with Air Liquide we've been able to do request 4-hourly urgent verbal hoofs because we very often don't get back to an office if we're going on to another visit afterwards. Is there going to be the ability to have a 4-hourly urgent verbal hoof?
The intent that we have is that the portal can be used anyway. You can use it on a smartphone, a tablet, a regular PC, a laptop. So you could actually submit it from the patient's home if you wish.
Right.
But the absolute, just to say, the absolute default, if you really were, unable to do it, then you could phone up.
Very often it really is only kind of an emergency if we know we're not going to get back to the office really.
Yeah, the only time that we have reservations on the whole with this, but it's normally Part A prescribers when you have an out of hours GP who will give a verbal for the oxygen to go in, and then we spend a long time trying to chase for the documented hoof because it should follow on within 24 hours.
Yeah.
So that's the only reason. But yes, if it's absolutely necessary, then yeah, we would take a verbal hoof.
100%.
Yeah, thank you.
Excellent. Next, Jackie Truman.
Yeah, a useful facility that was put on the Air Liquide portal, and I don't know if I couldn't see it when you went through your presentation with the BOC portal, was that when you've gone, that before submitting, it came up as preview, and it used to pop up the preview looking at like it would do as a paper document, because sometimes you'd enter it on the portal and then submit it and it hadn't gone through correctly, and it was just really useful to have that pop up that you could preview it.
Yeah, it is a good thing.
Yeah, I use it all the time.
You get to stage 5 of a complete hoof, you get to review the entire hoof at that point. So you get to see what all the fields are before you submit it, and then you click the buttons. And then once you have submitted it, you can then download it as a PDF. So you will get the opportunity to see it before you click submit.
So it'll come up to preview it.
Yep.
Yeah, okay, that's fine. Good.
And next question is from Linny.
Yeah, thank you. A couple of things. So do you deliver on weekends? Because when you say your 3 business day delivery, does that include Saturdays?
For free business day, no. If you require a weekend delivery, you would need to request it as a next calendar day or as a 4-hour if appropriate.
Okay. And I know you're going to get to the reporting bit next, but is there a facility where you can look at live new patients? So you say that if we as HOS leads haven't submitted the hoof, we don't get a confirmation email from other people who have done. But can we then go on the portal within hours or within the next day to see new hoofs that have been generated?
Yep, that will be part of what we'll be uploading on a daily basis. It will be an Excel document that shows new patients on a rolling 28-day basis. So that'll include all the relevant information for them, like their hoof details as well, what they're prescribed.
Okay, thank you. And then, sorry, just last one. Is this all going to be from the 19th of October? Will all our patients' details be on the portal and ready for us to use on the 19th of October?
Yes.
Okay, thank you.
Great. And lastly, I believe we have a question from Bryony.
Thank you. Just a couple of questions. The first is, you said that you could only complete the hoof for your CCG. What I wanted to check is we actually cover, we're now what we call a mid-knot service. So we actually cover Newark and Sherwood, but we also support Mansfield and Ashfield. So will we be able to complete hoofs for both those CCGs?
Yeah, sorry, I apologize if I misspoke. When you complete a hoof, there's no restriction on who you can prescribe for. You could, in theory, prescribe for someone anywhere based in the country. The CCG that you register as determines which patients you can see on the patient dashboard. But if you require access to multiple CCGs to see multiple groups of patients, we can provide that as well on request.
Sorry, and my second question was just about medium concentration masks. What is your stipulation about being able to order them and what flow rates?
Claire, would you be able to answer that if that's okay?
Yeah, sorry, what do you mean, Bryony, with you mean the Venturis?
No, so we've also had the option of being able to order medium concentration masks which don't have the Venturi valves on. And I think the manufacturer's guidelines are anything above 4 litres. Again, for patients that have variable flow rates that are ILD and don't retain CO2, they're really useful for those patients. So is there an option to order those?
I think I need to look at the contract and the consumables that we need to deliver, and then we'll take this from there, Bryony, if that's all right.
Yeah, that's fine. I'm sorry if you can hear grumbling. My dogs have just started to bark. I keep trying to shut them up. Sorry.
That's quite okay. Okay, does anyone else have any other questions before we move on to the next section and away from the portal?
I just wanted to respond to something Linny said about expectation that we were moving on to reporting. We don't today. Joe has just given a really high level explanation of where the reports are, who can access them, but that's those will be subject to a webinar that we plan after go live. Once all your patient data is in the system and they'll make sense to you, that's when we're going to run a separate session that goes into the detail of the reports.
Okay, thanks.
Excellent. Before we move on to the next section, I'll just mention some small things as well, which is that if you are already registered on the Home Oxygen portal, I'm more than happy for you to start playing with it. You will not be able to see any PID, of course, because there won't be any from the East Midlands on there yet. Well, you can experiment with how prescribing works, how you create a hoof. We would just ask, of course, that if you do then create a hoof in there, you do not submit it until, of course, after go live as appropriate. And again, the email is there. If you have any questions or queries and you want to speak to me directly, feel free to email at that address and I'll be more than happy to give you a hand. There are, as I say, video guides on how to use the Home Oxygen portal provided in the video library. Definitely give them some time to check those out. And otherwise, I really look forward to working with you all. It's been lovely meeting you today. Thank you very much.
Thanks, Joe. So now we're BOC, safety is at the forefront of everything we do, so we could not finish or omit safety from this webinar. So Hazel and Claire between them will cover some of the safety aspects of our service that are relevant to new hoofs, new patients. Over to you, Hazel.
Okay, so just to start really with this section, with the patient handbooks and all the equipment manuals that are provided to patients on install, it gives them kind of how to use the material or the machines that they've got. And it also does cover sections in there with regards to dangers, and it has kind of what to do, safety do's and don'ts, cleaning, maintenance, troubleshooting, etc. So that will be provided to patients on installation. And those handbooks will also be available on the internet and on the portal for the patients as well.
Make every contact count. So I mentioned this briefly when I was talking about Julie's role as respiratory advisor. So in partnership with the NHS, this has been something we've been doing for many years now, with increasing different topics that we feel are relevant to approach. So this is when our technicians go in and deliver these contacts of education and advice through what's been approved material. So in the past, we've looked at winter health, we've looked at nutrition, trips and falls, what to do in the heat wave, some education on managing breathlessness, and medication compliance. Now, when we talk about medication compliance, we're not expecting our technicians to be pharmacists, but this is where we found that we had lots of feedback of technicians coming across patients who hadn't had their tablets when they'd visited, or had a pile of tablets on the side, or just loads of medication around where the patient was, which of course is a safety concern. So from this, we thought, well, what can we do to make every contact count? What can we do to try and bring about a change for the patient here and support their well-being? And this is where we then devised a 4-question set, which elicited a yes/no answer. And from that question set, this was then escalated through to PSC, so in Worsley, and then on to the patient's GP, the patient's pharmacist, or the patient's prescribing clinician to highlight the issue. And it proved really successful, and is something that the topic bring Met to East Mids as well. And I'm not actually sure if you've been doing this previously or not, but yeah, it's a really good area. Thank you. So looking at oxygen hazards, there are so many hazards when we start to think of putting oxygen in for our patients. And on the left side there, you can see the general hazards that we need to consider, and our patients need to consider as well. So without frightening patients, it's about understanding there's increased fire explosion risk due to having pressurized cylinders there. Patient will be oxygen enriched. And what does that mean? So ensuring that patients understand about the oxygen on their clothes, the oxygen on their bedding, moving around with oxygen as well. So whether that be trying to use cylinders, position cylinders, and any musculoskeletal issues. Anybody needing oxygen is at additional risk of slip, trips and falls, whether that be from the hypoxia driving that need, or whether it be the equipment as well. So we've done additional work to provide DVDs to really highlight to patients they need to factor in this additional risk and some basic steps they can take to minimise slips, trips and falls. We also then consider the risk of tampering with oxygen equipment, and we've had situations before where patients become very hypoxic, confused and altered all of the oxygen tubing, or patients try and bypass different tubing to enhance flows or get rid of fire breaks. It's a hazard. Cylinder quantities as well. So the maximum cylinders that we would accept in a property would be 8, and that's only if that's needed. But beyond that, it really does pose an additional risk, and we have to question with prescribers whether that's needed, or is there a safer way to manage the oxygen needs of that patient. We look at the storage of oxygen equipment, and that would be visually check in where cylinders or liquid oxygen is, and our stipulation on our field-based risk assessment is for liquid oxygen to be stored in an area where it can vent off easily. So primarily this is outdoors of the home, and we wouldn't sign off approval for liquid oxygen to be stored within the home. And I think in East Mids historically this has been approved, but unfortunately through lots of further discussions and SHEC input, that's our safety governing body input, this isn't something that we can agree to and move forward. So you'll see some changes with liquid oxygen storage moving forward. And then of course there's the fire safety. So when you've got your oxygen enrichment, you've also got the issues of fires, ovens, radiators, makeup, hairspray. In the east of England, we've got lots of rural places, so patients might have open fires. And of course, the storage of oxygen needs to be 3 meters away from an open fire, 1.5 meters from electric fire. So we have to factor this in. And with the oils and creams, I think there's been lots over the last few years about the additional risk this poses, and it's about the risk benefit equation here. So if you have a patient who has something like skin cancer, for example, is there a suitable alternative, or what steps can be taken to try and mitigate or minimize that risk, whether it be advising 60 degrees wash of clothes, whether it be discussing with the pharmacist how long it takes for the oils and cream to be absorbed into the skin, into the dermal layer. So there's lots more that we look at here, and we pose the question back to pharmacists as well to say, is there a suitable alternative? And I can see their electronic devices. So actually it's a bit of a minefield for patients when they start oxygen, and for clinicians to factor everything in. But in all of these areas, there are normally suitable alternatives or ways to minimise these hazards that are in place. Thank you.
Hi.
Thank you.
Thank you. So in terms of risk assessments, there's 2 different risk assessments that are completed in a patient's for a patient. So there's the desk-based risk assessment, which is the very first time that we assess patients' risks. And this is when we're organising the installation for the patient. So the PSA would ring the patient and complete the DBRA. They have a very structured guided tool that they use, and they ask and we record all the responses. And it's only once we've got confirmation that the risks are addressed and we're happy with the risks at the patient's home that we pass the order on to the HT, the technician. And then during that DBRA process as well, we also capture if patients got any COVID symptoms or any risks aligned with COVID, or if they have any other impairments that we need to capture as well, whether they should be blind or have any hearing impairments. So once we've done the DBRA and we're comfortable with everything that we've got there, we then pass it over to the technician, and the technician then does a field-based risk assessment. So whilst it's at the property, he'll be looking for, it's got a much better option to look at other risks that you can't see over the phone. So we're looking for clutter, any trip hazards, to see if there's any signs of smoking or vaping in the property that needs to be made aware of, so we can educate the patient. And on there is a rare occasion where potentially the technician could be there and deem that installing the equipment may pose a higher risk to the patient or other members of the household. So at that point, he'll then discuss that with his team leader and the clinical lead or respiratory advisor for the region, and then a discussion with yourselves or the prescriber to decide what the next steps will be. Most times the risk can be mitigated when you're at the patient's home through some education, but there are rare occasions when sometimes we just need to pause and rethink what we're doing to make sure we're doing it safely. And ultimately, the idea is just to make sure that all the risks have been. Oh, sorry, Claire.
Sorry, Claire. Hazel.
The overall aim is just to ensure that we get the oxygen used safely and all the risks are mitigated. It's also kind of really important to share with you, I think, that in terms of risks, we don't just look for risks during formal risk assessments. We do dynamic risk assessments all the time. So the advisors on the phone will pick up if a patient's overusing their oxygen, or if they tell us that they're using a prescribed rate or a rate that's not what they've been prescribed. or they advise us of something that's unsafe or something that makes us think maybe they are a bit confused or there might be a safeguarding issue, then we kind of will flag those, as we call them, safeties, and then we'll alert the team that's responsible for the patient to make them aware. I mean, at the same time, when the technicians visit the patient's home, they're also looking to spot different risks as well. So, as you know, as a patient, their life on oxygen, they may well deteriorate from when they were first installed. So we also kind of keep an eye on the patients, and if we do see something that, you know, now they might pose more of a risk because they've become more frail, and they might be more at risk or prone to trips, then we'll flag those up as well, so that we can make sure that we support the patient and mitigate that risk for risk falls. Thank you. You can go. So in terms of series, we if a patient is caught smoking on oxygen or fails to comply with the 20-minute rule, then we would raise a series for that. So that's a series incident requiring investigation. So we'd report that within 24 hours and we'd cascade that through to the CCG. Usually at that point, there's some multidisciplinary teams involved, and we all try to understand what the best thing to do for the patient. So if the patient if they've been caught smoking on the oxygen, or whether they've actually burnt themselves. At the installation point, there's a lot of work done from the technician to educate the patient to make sure that they know about the dangers. So we're not saying that patients can't be a smoker and have oxygen. They just need to understand the safety rules to make sure that they don't hurt themselves or anybody around them. Once we identify
just to highlight it. Sorry, Hazel, I was just going to highlight that as well, to include the use of e-cigarettes also. So we've done lots of additional work on what risk is posed by our patients using e-cigarettes, because that's been a big step for smoking cessation to step down to e-cigarettes along the chain of eventually hoping to stop smoking. Sorry, Hazel.
Okay, thanks. So once we know a patient's a smoker, so we may have flagged that up when we did the DBRA, or it could be through the FBRA because the patient might not have, wanted to share it over the phone. So, but we can see that they're a smoker. We capture those in our system, and then we also advise the fire service as well. So the fire service will know the smokers in the region, and we'll keep them updated. But if the patient is caught smoking, we do everything we can to re-educate them, to ensure that they smoke safely. And then we would send them, I think we have like a yellow and red card system. So on the first kind of occasion, they'd get a yellow card and they'd sign a high risk letter to confirm that they understood the risks associated with smoking, and that they were happy to smoke safely, and that we'd inform the fire service additionally. Were you going to say something, Claire?
Yeah, no, I was just going to say that just as Hazel said, that absolutely from the beginning, if someone's highlighted as a smoker, there's loads of additional steps we put in to make sure that they are making informed, sensible decisions to 20 minutes off their oxygen before they smoke or light e-cigarettes. And then for us, it's really simple with the yellow card and red card approach. And then we move into a cooperative kind of, let's call together all the relevant parties to have an MDT and to see how we can mitigate the risk. So it's partnership working, collaborative working, but fundamentally, if those risks can't be mitigated, then our move would be to withdraw the oxygen in the interest of safety. So whether that means that results in admission to hospital or relocating the patient to a different home setting or accepting a lower PO2 or saturations, then that would be the ultimate decision. And some of the things we look at are, do they live in a terraced property? Do they live in a flat? Because there's much more additional risk to other people and neighbours. Who else lives in the property as well? So it's just to really highlight to you, these are difficult, complex cases, but the bottom line is facial injuries or burns do happen and fatalities do happen. So we always need to be very proactive. Sorry, Hazel, that's all I want to say on that.
That's that slide covered. Thank you.
or the last little nugget of wisdom from Niall. If he was here, he would have also quoted that the fire service have said from start to finish, with an oxygen and fire fatality, it costs 1 million at least. So huge expense as well. Thank you.
Thanks, Claire. So I suppose the final bit from me really is just from keeping in contact and working in partnership with you guys that prescribe for patients. We want to kind of work with you as much as possible. We want to make all our lives as kind of seamlessly as work seamlessly as we can, to make sure that we do the best by the patient. So if we do find something out during a phone call with a patient or while we're in a patient's home, we would flag this to you. So there could be various reasons for that. So smoking, other safety reasons, some safeguarding concerns. If a patient wants a different type of modality, if they've asked for their equipment to be removed because they're not using it anymore, if the patient, we can't contact the patient for some reason to do the installation or to do the script change, or if we move the patient into a PEP, then we'd always try and ring you first to try and have a conversation to let you know that this is what we've identified. But we do have a clinical escalation form, so we'd always send you that as well, an email, so that you can just see what we're trying to get in touch with you with regards, so that we can make sure that the accounts or the patient has everything that they need, and that we can mitigate any risks that crop up.
And any questions about any of the safety procedures that we have in place?
So I can see Sue Smith's raised a hand.
Hiya, just a very quick one. Well, a couple of things actually. One's safety and one's to do with the hoof earlier on. You've said on that last slide about the patient, the escalation form.
Yes.
Who is that flagged with? Is it with the prescriber or is it with the HOSAR team? Because an awful lot of times, especially if it's acute or if it's a Part A, or the prescriber won't really have a clue if you escalate it to them, whereas the HOSAR team that look after the patient will.
Yeah, so we'd always try and get, if there's a HOSAR service covering that area, we'd always try and send it to the HOSAR service. And
Yeah.
failing, if it's not covered by a service, it would usually probably be the GP that would end up going to.
Yeah, good. And just really quick, some of our patients are on either NIV or CPAP. Do you provide the connectors for the oxygen, or would we have to do that? There's a tick box, isn't there, on the hoof form? I don't know whether Joe or one of you. So the tick box on the hoof is about NIV or CPAP. Would you provide the connector, or do we have to get that ourselves? Because at the moment it's not provided.
We don't provide that, so
Right.
that has to be from who's doing the NIV or CPAP.
That's fine.
Thanks, Sue.
Any other questions? No? Okay.
Oh, no, I've got one.
Sorry.
Karen.
Can you hear me?
Yes.
Hello?
There's a lot of echo. We can hear you now. Hi.
Saying yeah. Hello?
Hi.
Oh, sorry, my fault. So yeah, I'm just curious about PEP. At the minute, we've got 4 or 5 patients in PEP, and we've spoken to them on the phone, we've texted them, we've sent letters, and they still haven't contacted Air Liquide. I'm just wondering what BOC does in that sort of situation. At what point do you pick up that you need to get in and check your equipment? Does it all fall to us, or is it shared?
It would be shared. So we would contact the patient. We wouldn't just put them in PEP and leave them in PEP. We would still try and contact the patient to get in with them. But it was just, we'd ask for your support to try and get them to reach out to us, or if you had a different number for them, or
Yeah.
it could be a different way that we can, arrange to go and see the patient.
Yeah. Okay. Thank you.
No problem.
So, okay, we'll move on towards the final straight. So thank you, everyone. Thank you for all your questions and your points of improvement for future runnings of this webinar. Hope that you've found this session useful and that you now feel comfortable, that you know how to engage with us and how to use our portal, how to get started with it, at least from Monday the 19th. Looking back at what we hope to achieve today, I hope you can now put some ticks against each of these learning objectives. So what's going to happen next? Within the next few days, we'll send you a questionnaire for you to share feedback on today's session to help us improve future webinars, whether it's this one or the format of others that we plan, such as the reporting one. Equally, if you've got suggestions for any topics that you'd like us to cover in future webinars as well, please let us know. And if any questions come to mind once you've watched back this video or have gone through the slide pack again, if anything comes to mind, please feel free to contact us. So as I said, you'll receive the recording, share it with those individuals who couldn't attend today and who aren't able to attend any of the other sessions. Possibly also if you know of colleagues who haven't yet opted to attend any of the webinars, hopefully you'll feel positive about this and encourage them to submit their request to attend some of the other dates that we've got available. With regards to videos, though, don't forget there's also the how-to videos that Joe referred to in the download, in the video library section on the portal. We'll also send out to you, and it will be available on the portal, a handbook for healthcare professionals, which explains more about us and our service and the different elements of the service. So we'll share that with you. Again, you can share that with colleagues as well as a reference document. And as we'd said previously, we'll type up the questions that were asked. And if you squeeze any into us by email over the next few days, we'll share a Q&A document with you, and we'll keep that document live. So we'll put it in the portal. And as we do the other webinars, other questions that come up from other prescribers, we'll update that document so that you can see all of the questions that have come in from your prescribing colleagues across the region. We'd also mentioned a few times that we're going to do a webinar after go live focused on reporting. So we'll get details of that out to you with dates for you to hopefully work out which date works for you and indicate which one you'd like to be invited to. Final bit of information wanted to let you know is that from next Monday, all oxygen patients will be sent a letter reminding them of the change to BOC because they had received a letter about a month ago. This letter, however, unlike the first one, will provide our contact details for patients to get in touch with us. Should patients ask you about the handover or specifically about the letter, or as and when you're engaging with oxygen users in your scheduled appointments with them, the key message to share with them is that they don't need to do anything themselves as part of the handover to us. All of their information will transfer to us. They keep their current equipment from the 19th. Their servicing schedule and any scheduled deliveries that they have will be taken over by us from the 19th. The only change for patients is that they'll need to call BOC for anything to do with their oxygen equipment, so refills or technical issues, holidays, not that many people are doing those at the moment. So they just need to call us from the 19th. The letter that they'll receive next week has a little cut-off voucher slip at the bottom that sort of pocket size that they could keep next to the phone for reference, or pin on a notice board in the kitchen. If they do forget, that that they need to contact BOC from the 19th, and they still call Air Liquide after that date, the Air Liquide 0808 number will be transferring to us on that date. So their call will still come through to us. If they leak into Air Liquide through other means, the Air Liquide contact centre team are briefed on our contact details and how to inform patients that they need to contact us. So apart from that, just leaves us to say we really look forward to working with you and supporting your patients from Monday the 19th, and and also to remind you, until that date, please continue to engage with Air Liquide about all your existing patients. We do not have details of the patients until that date, so you still need to deal with Air Liquide for anything until then. And apart from that, goodbye from all of us, and I'm sure we'll be engaging with you regularly from the 19th. So thank you very much for your time.
Claire, sorry to interrupt. Yep. We've got a few hands raised.
Oh, sorry.
I'm not sure if we've got a few questions before we finish. Are we okay to take a few questions? Yeah. Sue, I think you raised your hand.
Sorry.
Sue Smith, sorry.
Yeah. So the patients are going to get the letter on the 5th about the changeover and the contact details. In that interim period, if they call BOC by mistake, are they going to be redirected back to Air Liquide, or what's going to be the process?
They will be. Well, if it's relating to their existing oxygen equipment, then yes, we will advise them to call Air Liquide. If they're calling us because they wanted to know a bit more about the transition, if they're seeking assurance, then we'll deal with it.
Yeah, that's fine.
Joe, you raised your hand as well.
I did. Just wanted to mention, following what Claire said before about the clinician's handbook, that is now actually available on the portal for you to download from the download section. So if you are already registered, you are more than welcome to log in, find that section, download that handbook for your own use.
Thanks, Joe. Bryony?
Hi, thanks. Sorry, I've just got a few generic questions. I don't know whether it's appropriate here if you want me to speak outside. My first was about milk rounds. So historically, patients that have ordered a lot, Air Liquide have automatically put on milk rounds, and we weren't automatically made aware. Is that something that you do? Do you organise that with the patients directly, or do you get the prescriber involved as to whether or not they need them?
It can depend really on what you want to do. I mean, looking at the information we've got, there isn't many patients on milk round in the region at the minute. But do you have a view on how you'd want it to work, Bryony?
Only because I've got some of the specific patients, shall I say, were probably misusing. They weren't actually going out and using ambulatory around the house as opposed to their concentrator. So because I wasn't necessarily aware until I was due to review them that they'd automatically been put on the milk round, it wasn't really appropriate that they had sort of Monday, Wednesday, Friday deliveries because they had the concentrator available to use.
Okay, we can definitely, we wouldn't just, and we probably would liaise with you guys to make sure that it was appropriate for the milk round.
Okay, my second question is just what actual brand of consumables do you use? So I'm asking this because I've got a specific patient who doesn't have a latex allergy, but he actually has a reaction to whatever the chemical that Salter uses to clean their products and to sterilise it. So he has to have a very specific type of nasal cannula which has been provided. Is this something that you would continue if our patients do have reactions to a specific type, that you would be able to continue on them using the ones that's most appropriate for them?
It's quite difficult to do individual requests, but what you give is the clinical justification, as you have done, Bryony, and then we'd probably pick this up separately to see what our equipment is and what the issues are, and then what needs to be provided, and in some cases maybe include conversation with the CCG to say that this is what we're needing to do.
So if that's already in place now, is that something, so again, just thinking about your Inogen conversation and the second battery, I've only got one patient that's got a second battery, and I'm just thinking about these nasal cannula. Do I need to start those conversations with the CCG now to get additional funding, or will you automatically, because it's already been approved, transfer it over?
I think it would be really good to start, and I don't mean to add additional work, but to start afresh to understand what's gone on before and what's needed, so that we can see if there's anything that BOC would do differently. But if you want to pick this up with me separately, Bryony, and send some details to my NHS Net, and then we can see the best way forward.
Okay, thank you. That's helpful. Thanks.
I don't think there's any more questions.
Nope,
nothing else there.
Okay, so thank you everybody, and we'll close the session for today. Thank you very much.
Thank you.
Thank you, everyone.
Thank you, everyone. Take care.
Thank you.
Thank you. Thank you for your time.
Thank you.